On global map, Indian subcontinent shows the highest burden of typhoid fever, with our neighboring country Pakistan showing increasing incidence of extensively drug-resistant typhoid since year 2016. And Widal test remains the most commonly prescribed investigation in developing countries. Here I am Professor Anuradha Sharma discussing some important insights on lab investigation of typhoid fever. In a recently published article, the annual incidence of typhoid fever in India remains 4.5 million cases with annual deaths of 8,930 cases. The antibodies are detected by Widal test, which develop after 10 days of infection. So any investigation done before this will give a false negative report. Similarly, use of antibiotics also doesn't allow the rise in antibody titer, producing a false negative report. So a misdiagnosis will lead to further higher, costlier investigations and patient ending up with inadequate treatment with complications or deaths and hospitalization, leading to increased burden on the healthcare system. Similarly, there can be false positive reports because of prior exposure and antibody levels, and vaccination and anamnestic response to other infections will also give the same results. This will lead to misuse of antibiotics, and that is how there has been emergence of multi-drug resistant typhoid in the past, and now we are seeing extremely drug resistant typhoid in Pakistan, which remains sensitive only to azithromycin and carbapenems. Blood culture is the gold standard to identify typhoid fever, and it detects 90% of cases in the first week itself when up to 40 ml of blood is cultured. That means 2 sets of blood culture bottles, each set inoculated with 20 ml of blood. And this sensitivity increases further to 98% with the third blood culture set. And in children of different age group, different amount of blood should be cultured. The new serological diagnostic test promising result in few minutes to few hours are not required because they will lead to missing the patients as well as overdiagnosing the patients, and it will not provide the true sensitivity profile of the pathogen. And in our country, different types of isolates are circulating because there is a regional variation with different sensitivity profile, and we have the option to select cheaper and less toxic drugs with best outcomes. So need of the hour is cheaper automated blood culture and sensitivity testing for resource limited countries. These drugs also carry several contraindications as well as safety concerns. So without any proper laboratory support, they should not be prescribed. So we have to use these antibiotics responsibly, and we need to avoid combination drugs for typhoid fever like cefixime with ofloxacin. It is not prescribed by any guideline, and it will lead to severe dysbiosis in the patient, leading to emergence of extensively drug resistant pathogens. Also, azithromycin remains the drug of choice for several important respiratory, diarrheal, and sexually transmitted infections like gonorrhea. So, use these antibiotics smartly and save the patients. Thank you.